Well, welcome everyone to our On the Pulse series. We're so glad to be back with a new season of offerings. I am Chris Fortman, the CEO of the Minneapolis Heart Institute Foundation, and I am so glad you made the time to join us today to hear a little bit from our physicians. And before we get into our keynote speaker, I would love to give you a little background on the Minneapolis Heart Institute Foundation. So we are an independent nonprofit research and education organization, and our great work is made possible by our unique partnership with the Allina Health Minneapolis Heart Institute. So as a research and education organization, we partner with very busy cardiologists and surgeons who have real-time questions, and we bring that all to life, and all of that work improves our clinical practice. Here are some examples of how this happens. Our mission is to improve cardiovascular health through innovative research and education. So right now we have over 200 studies underway, touching the lives of over 2,000 patients. And this is physician-initiated research and industry-sponsored clinical trials. And it's so important to have that mix and that number of studies because it offers options to our patients. In addition to the research side, we are committed to educating the community and the next generation of healthcare providers. One of our great programs is our internship program, where college students come for the summer and partner with a physician and a research staff to do real-time research and often present at conferences. Most of our alumni are either practicing physicians or currently in medical school. We also provide ongoing continuing medical education opportunities, community education, and of course are very committed to publishing all of our research findings in peer-reviewed journals, and that number is about over 200 annually. And this is a special year for us because we are celebrating our 40th year anniversary, and we've been able to continue this work for the past 40 years because you can see many of our values to the right. That's operating with innovation, ensuring impact, being agile, really leveraging our passion, always expecting excellence and quality, and most importantly, having those options for our patients. Here we have a summary slide of really what has changed from 1982 to 2022. As you can see, the aqua colors show the numbers of MHIF, the number of physicians at 13, staff at 5. And you can see where we are today with the partnership with over 100 physicians, with 80 plus staff ready to support research and education opportunities, a $16 million investment, and again, publishing more than 3,000 peer-reviewed manuscripts in this time. And the story goes on. I just wanted to share this with you because we are so excited, not only to celebrate the last 40 years, but to look forward to the future. And this is probably one of the most important slides. And this is really to say thank you. We are so grateful for the community partnership and the many people and organizations that make this work possible through their very generous philanthropic contributions. So with that said, it is time to get on to our keynote. I am excited to introduce our speaker for today, Dr. Retu Saxena. Dr. Saxena is a cardiologist at the Minneapolis Heart Institute. Her interests are women and heart disease, cardio-obstetrics, prevention, and non-invasive imaging, as well as cardiac critical care. She will be the first female governor of the Minnesota chapter of the American College of Cardiology. She is also the mother of 2 active girls, an avid reader, and a passionate gardener. And with that, I will hand it over to Dr. Saxena. Thanks.
Thanks, Chris. Good afternoon. I'm going to talk to you this afternoon about women's heart health. Let's start with a year, 1908. In 1908, heart disease officially became the #1 killer of women in the United States. Since that time, as you can see, heart disease has remained the #1 killer of women in the United States, accounting for, in 2018, about 420,000 deaths. Women make up 49% of all cardiovascular deaths. Not only is it a hugely mortal condition, it is also a hugely expensive condition. In 2016, cardiovascular disease was listed as the first diagnosis on 2.2 million discharges for women throughout hospitalizations in the country. And then in Minnesota, 6% of women are living with or suffering from cardiovascular disease. In May of 2021, The Lancet, which is a large British publication, quite well renowned across the world in medicine, actually commissioned a group of women physicians to look at heart disease worldwide. And they also looked for solutions to decrease the number of heart disease patients worldwide. And what they found was that 35% of all deaths in the world are due to cardiovascular disease in women. About 275 million women in 2019 were diagnosed with cardiovascular disease, and 9 million of those died in 2019. Now, we know that for a while, up until about 2010, cardiovascular disease deaths were on the nadir. But recently, we've seen those previously favorable trends go away, and more individuals are dying from cardiovascular disease, both men and women. We know that women are underdiagnosed, undertreated, understudied, and underrepresented. Our mortality is significantly different than in men. When you take a look at women and you look at them 5 years out after a heart attack, you notice that women are more apt to die than men are, even though the prevalence of those women living with heart disease is a little bit less. For those of you who know me or who've heard me speak, it's very, very hard for me to do any talks without throwing in a slide about maternal mortality. So I've, of course, thrown in several. My passion is cardio-obstetrics, looking at that intersection between pregnancy and heart disease. And in this country, we have very woeful heart disease, maternal mortality statistics. We've had continuous rise in the deaths in our pregnant women over the past few decades. In 2018, the United States government actually passed the Preventing Maternal Deaths Act. Since 2018, which are these bars down here, we've seen a steady increase in the number of women dying from heart disease, especially when it comes to women who self-identify as non-Hispanic, Black, and Hispanic women. We notice a steady increase. So why, as a cardiologist, should we worry about or think about maternal mortality? Well, it turns out the number one reason that these women die are things I do day in and day out in my general cardiology clinic. These women die from heart failure, hypertensive disorders, blood clots, things that cardiologists are very adept or should be very adept at taking care of. We know that deaths vary by race. Women from Black identifying or Hispanic tend to have more issues with preeclampsia, eclampsia, and blood clots. Women who are non-Hispanic white tend to have more deaths secondary to postpartum depression, mental health disorders. And the majority of these deaths occur about 42 days after they deliver. So this is the time period where women are being seen by emergency room doctors, primary care providers, and may no longer be evaluated by their OBs. What's really distressing to me, as is many of the things I do in cardiology, 80% of these deaths are preventable. So if you look here, this is from California, which is the one state in the country where maternal deaths are actually on the decline. What they found was 80% of all deaths could have been prevented in pregnant women. And when you look at the cardiovascular deaths, it's over 80% could have been prevented. And the number one cause that could have been changed, the thing that could have been changed that would have led to an improvement in outcome, is actually paying attention to clinical warning signs. Another reason why cardiologists should do this, because in clinic, if I were to see you as a patient, I would ask you about those traditional clinical warning signs. Whether you are a 30-year-old woman that's pregnant or you happen to be a 97-year-old man with heart disease, the questions remain the same. Are you having chest discomfort, shortness of breath, swelling in your legs, racing heart, issues with your vision, blood pressure, and either too low or too high? If we had paid attention to these symptoms, again, 80% of the deaths in this study could have been prevented. And because it's such a complicated field, cardio-obstetrics, we know that it takes a village to take care of these women. Women who have heart disease or are at risk for heart disease when they get pregnant, of course, have a higher level of morbidity and mortality. And so we at Allina Health have a cardio-obstetrics team that is made up of high-risk obstetricians called maternal fetal medicine doctors, pharmacists, social works, cardio-obstetric experts, cardiologists from all disciplines, heart surgeons, anesthesiology, primary care, and then, of course, a nod to our nurse coordinators who actually run our program. And what we do is we evaluate women all the way from preconception, where, yes, we talk about contraception that's okay to use in heart disease. We risk assess them, tell them whether or not they would be safe or high risk to go on and get pregnant. We manage them through pregnancy, help give guidelines for labor and delivery, and then, of course, evaluate them after delivery and then within the week to 2 weeks afterwards, which is again their greatest risk of having problems, and then the further long-term cardiovascular disease risk and screening. And so, as Chris said, we are fond of research and we love looking at outcomes, and this is actually data from our cardio-obstetrics program. We had this as an abstract in fall of 2021 at the American Heart Association. And fortunately for us, when we compared our two groups, so we looked at our cardio-obstetrics population and compared them to a historical group prior to the inception of the cardio-obstetrics program, what we found was that there was no difference in maternal mortality, thank goodness. But what we did find was that women who are seen in a multidisciplinary format are less likely to be readmitted and less likely to be seen in the emergency room after they're evaluated in a multidisciplinary format. So again, more to come on this. It's ongoing work. So to switch gears, women get pregnant. We have significant hormonal differences compared to men. And I like to say we are not just small men. We know that our symptoms are different than men, although women do get chest discomfort. If you happen to be a younger woman, you're more likely to get chest discomfort. Now, your chest discomfort may not actually be in your chest. It might be in your jaw. It might be in between your shoulder blades. It might be in your shoulder. But women do get some form of chest discomfort. Older women are more likely to present with their heart disease in terms of having shortness of breath or weakness or fatigue, sometimes things we get when we're on call too long and we have sleep issues. But again, women do, about 50% get chest discomfort, especially if you happen to be a younger woman. The other sign and symptom to pay attention to is shortness of breath, especially if you have shortness of breath with things that you normally do. Women often lack awareness that heart disease is the #1 killer of women in this country. So again, 1908, first year that heart disease became the #1 killer of women. In 2009, there was a study looking at women's awareness, so this is individuals out in the population, awareness of cardiovascular disease being the leading cause of death in women. At that point, 65% of women knew that heart disease was the leading cause of death. They looked at this again in 2012, and they looked at it and broke it down by ethnic variations. And what they found is that although 65% of white women knew that heart disease was the #1 killer of women, when we looked at Hispanic and Black women, only a third of the women interviewed realized that heart disease was the #1 killer of women. And then we've done really poorly over the last decade. In 2019, they redid the study looking at women's awareness of the #1 cause of death. And we've fallen to about 44% of women across the board understanding that heart disease is the #1 killer of women. What do they think is the #1 killer of women? Actually, cancer. It's not, thank goodness. Turns out 1 in 32 women with breast cancer will die from breast cancer. However, they're more actually likely to die from heart disease. And remember, in our population, 1 in 3 women will die from heart disease. So again, we have some work to do. We need to spread the word and raise awareness that heart disease is the #1 killer of women. The other thing that women tend to do is we tend to not understand our symptoms. If we're not aware that heart disease is the #1 killer of women, we often attribute our symptoms to other things. Not only do we ourselves underappreciate and lack awareness that heart disease is the #1 killer of women, what's quite disconcerting is physicians also do not understand that heart disease is the #1 killer of women. This was a study that was done at NYU, New York University Langone Hospital. They looked at 29 million emergency room visits for chest pain. Simple statement of chest pain. Nothing complicated, no shortness of breath, just chest pain. What they found was that women were less likely to be triaged as an emergency case. They waited about 10 minutes longer. Why this is important is if you're having a heart attack, whether you're a woman or a man, those 10 minutes are muscle at risk. So we always are taught in cardiology, the longer you wait with heart disease and heart attacks, the more heart muscle you lose. So women wait about 10 minutes longer to be evaluated. They're less likely to undergo an EKG compared to men for the same symptoms. They're less likely to receive heart monitoring or heart rhythm monitoring. And they're much less likely to be evaluated by a subspecialist, such as a cardiologist, and less likely to be admitted. Even on the outpatient standpoint, when women are complain of chest symptoms to their primary care providers, they're less likely to be referred for stress testing or an evaluation for cardiology to see them. Primary care providers in general do recognize cardiovascular disease as the leading cause of death, but more often than not, women are apt to get their mammograms checked off before their cardiovascular disease risk assessments done. Most physicians actually report suboptimal training in truly assessing cardiovascular disease risk in women. Fortunately, by the end of this talk, you guys will know more about cardiovascular disease risk in women than most primary care providers. Hopefully not. The other thing that we need to think about is other barriers to care other than the social determinants of care. There's an absolute social stigma that seems to be associated with cardiovascular disease. In a study that was done in 2017, looking at women's attitudes towards cardiovascular disease, about 26% of women actually felt that thinking about and looking at cardiovascular disease was embarrassing because they perceived it as solely associated to your weight. We'll talk about that as a risk factor in a minute. But then we all have this Wonder Woman phenomenon, right? We're too busy taking care of everything else, our job, our kids, our house, our garden, whatever, to be able to actually take care of ourselves. And hopefully we switch that. So our risk factors are a little bit different. As I said, there's this stigma that all heart disease is associated with weight. Well, it actually turns out that when you look at traditional risk factors, weight impacts women and men about the same when it comes to cardiovascular disease risk. So does cholesterol, so does not getting up and exercising, and so does your family history. These are equally weighted in men or women, meaning it doesn't pose more risk to women to be overweight than it does to men to develop cardiovascular disease. There are absolute traditional risk factors for cardiovascular disease that impact women more. Hypertension. Turns out about 80% of women over the age of 75 are living with hypertension. And in this country, regardless of age, only about 30% of women are actually getting to guideline-directed therapy goals. So we're not doing a great job of managing blood pressure, and I'll show in a minute why that's super important. Diabetes impacts women more than it does men, simply because we have smaller blood vessels, and same is true of smoking. Smoking is a higher attributable risk to women than it is men for developing heart disease. There are absolutely female predominant risk factors, things that impact women much, much more so than men. Things like lupus, rheumatoid arthritis. If you are living with a rheumatic disorder, you are about as much risk for developing heart disease as if you are living with diabetes. Depression and psychological stress I'll talk about in detail. And then there's the female-specific risk factors. If you happen to have the onset of your period before the age of 11, you're at increased risk for developing metabolic syndrome, things like diabetes, high blood pressure. If you happen to have early menopause, you're actually increased risk of developing both subclinical and clinical atherosclerosis or plaque buildup. If you have polycystic ovary syndrome, you're more at risk for developing diabetes and hypertension. If you've had amenorrhea for any reason, so your period's gone away for any reason, you're actually at increased risk for developing heart disease. And then the things that I think about, which are the adverse pregnancy outcomes, otherwise now known as risk-enhancing factors, things like preeclampsia, which is significantly elevated blood pressure in a very devastating way during pregnancy, or gestational hypertension, gestational diabetes. All of these increase our risk of cardiovascular disease, specifically coronary artery disease, but they also increase our risk for developing heart failure, stroke, and diabetes later in life. We used to think later in life was 30 to 40 years out. What we're learning more and more is that women will start demonstrating changes in their cardiovascular risk within about 5 to 10 years. In fact, if you've had preeclampsia, within 10 years, you're more likely to be admitted for heart failure than if you've not had preeclampsia. So I think it's really important to pay attention to these risk factors, and these are risk factors that are absolutely novel to women. So I said that women are not small men. We have very different coronary anatomies. Our coronary arteries, those are our heart arteries, they're much smaller than they are in men. We tend to have less focal stenosis, meaning we have narrowing that is not just at one point. Our narrowing tends to be diffusely across the blood vessel. We tend to have less hard plaque or calcified plaque. We tend to actually have more soft and vulnerable plaque. And we have a lot more vascular dysfunction. So when we look at the types of heart artery disease that women will often have, we absolutely have traditional atherosclerotic coronary artery disease. Plaque rupture leading to the big heart attacks that, again, you might see in the Hollywood type heart attack. Women have those. They just don't get portrayed in movies the same way that men do. But women are more apt to have different types of heart artery issues. They can have what's called vasospasm, where the blood vessel actually spasms. That can be either those big, juicy blood vessels that my friends like to put stents in, Or the small little vessels can also have microvessel vasospasm. The microvessels themselves can become dysfunctional. You can have spontaneous coronary artery dissection, which I'll talk about in a minute. We can also have heart attacks that are actually not heart attacks, but broken heart syndrome. Because women do present more often with heart attacks that aren't necessarily secondary to plaque rupture or a blockage, we've actually coined a term called MINOCA. The flip side of that is INOCA, or ischemia, meaning heart muscle at risk with no obstructive coronary artery disease. And we know that these can be for various and sundry reasons. Again, spontaneous coronary artery dissection, Takatsubos are some of the causes that can do this. But again, about 17% of this is from vasospasm. 50% of this is from microvessel dysfunction, so those little tiny blood vessels aren't working as well. And although the mortality rates, meaning we don't die as much from MINOCA compared to those kind of Hollywood heart attacks, we do know that there are similar rates of women living with ongoing chest pain or angina, having decreased quality of life, and they often come back with recurrent myocardial infarctions, even though they're not fatal. And because of this, we here at the Minneapolis Heart Institute Foundation are part of a national trial looking at women's ischemia. So we are enrolled in what's called a warrior trial, and we are enrolling now. So if you're interested, contact us. What we're looking at is it's the women's ischemia trial to reduce events in non-obstructive coronary artery disease. So women with ongoing cardiovascular symptoms who don't have a blockage. And it's looking to see if intensive medical therapy will improve outcome compared to regular therapy. And this is, again, just a trial in women that's funded by the University of Florida. So if you're interested, please get a hold of us. Spontaneous coronary artery dissection, much more common in women, and actually young women, not associated with a stigma of weight at all. Usually, no conventional risk factors. Precipitants can be extreme physical or emotional distress. We do see this in association with labor and delivery. What actually happens is the arteries of the heart have three layers: the intima, the media, and the adventitia. And what happens is the intima, which is the inside layer, actually peels away like a banana peel, and you can either develop a clot in that space, or you can tear that artery to the point where you obstruct, get rid of the flow down that tube, and that can lead to a heart attack. What we're learning more and more is that SCAD is associated with types of arteriopathies where the blood vessels aren't coming as normal as everybody else's. Upwards of about 70% of these women have a genetic condition called fibromuscular dysplasia, and unfortunately this is the first event that leads to it. Now the good news is that the majority of these women will spontaneously heal their heart arteries, but the impact of the heart attack can be devastating. Right now we're looking at our data for SCAD and catheter-based therapeutics. So that's research that's ongoing right now at the foundation. Other types of heart attacks that are more prominent in women are things like broken heart syndrome, where you come in, you're acting just like one of those heart attacks, but when we look at your heart arteries, you have absolutely no obstructive lesions, and this often gets better within about 4 weeks. 80% of these cases occur in postmenopausal women. We call this broken heart syndrome or stress cardiomyopathy, or the other term we use is Takatsubos cardiomyopathy. We're knee-deep in trying to figure out why this happens. There's been theoretical concern that this is a chronic small vessel issue versus an acute microvessel dysfunction. We recently had an abstract at the American College of Cardiology meeting in Washington, D.C., where we published our first 4 patients where we actually looked for chronic microvessel dysfunction using novel technology that's here at the Minneapolis Heart Institute, evaluating small blood vessels by cardiac MRI during the acute portion of the Takatsubos. This blue is abnormal, the yellow is normal, and as you can see, the parts that aren't working, that's the part that the Takatsubo impacts, is microvessally abnormal. What we presumed or hypothesized is that these women would have some degree of chronic microvessel dysfunction. And so we looked when everything went back to normal 6 months later, when the heart function recovered, and they don't. They don't have any evidence of chronic microvessel dysfunction. Stay tuned, we're enrolling more patients into this, and hopefully we'll have a better answer about whether or not microvessel dysfunction actually is the cause. So if it's not the microvessels, chronically, what could potentially be happening? Well, we know that stress, depression, anxiety, or emotional states impact us very, very differently than they impact men. Turns out depression is twice as common in women as it is in men. Women suffering from depression are 2 to 3 times more likely to have some degree of heart disease. Just to stick on the same theme of the Takatsubos, there was a really nice paper looking at those individuals whose response to stress was to light up the fear centers called the amygdalas in the brain. So this is functional PET in the brain. And what we're seeing here is that those individuals who go on to develop Takatsubos, we light up our fear receptors. So instead of fight or flight with the running, we now take our stressors and we get scared and we get stressed out and we then break our heart. So we know that our heart rates can go up, our blood pressure can increase. Turns out that the same fear receptors and that stress that our bodies go under is a pro-inflammatory or inflammation state. We know that inflammation is bad for heart disease. It also leads to our sticky cells becoming much, much more sticky, therefore not only increasing our risk for developing things such as Takatsubos or SCAD, but actually increasing our risk of developing atherosclerosis and heart disease down the line. These things lead to depression. When we're depressed, we tend to have poor choices in terms of our nutrition, our exercise. We tend to overeat, smoke, and not necessarily take care of ourselves. So I think treating depression is really important in treating heart disease. This is just an overview of the different types of heart disease. This is one area of heart disease that women can suffer from, both from the standpoint of the traditional atherosclerotic blocked heart arteries to microvessel dysfunction, coronary artery dissection, vasospasm, and then of course Takatsubos. This was a really nice article looking at the kind of guidelines for managing women in particular with ischemic heart disease. I bring this up because we know that there's significant disparities in care. In the last 37 to 40 years, the number of studies and the number of women enrolled in studies has remained less than a third. Studies haven't necessarily accounted for women. We just haven't enrolled women, especially women of childbearing age or women that are pregnant, to look to see how women do. Within the last year, the number of studies published looking at women and heart health, especially in the field of cardio-obstetrics, has skyrocketed. And simply because we know now that it's important to do gender-specific research. We know that there's significant disparities in care. We already talked about the disparities from the emergency room, but women in general, even if they do come in with that traditional Hollywood heart attack, are less likely to leave with guideline-based recommendations, such as statins at the right dose for cholesterol management to keep that plaque from being vulnerable. We're less likely to get referrals for and go to cardiac rehab, despite the fact that exercise might benefit us more. And we're less likely to get stents or percutaneous coronary intervention or coronary artery bypass grafting. This leads to more young women suffering from chest pain and significant decrease in quality of life and readmissions to hospital. Not only are we have disparities in this country when it comes to things along the roads of ischemic heart disease, there's huge disparity in things like cardiac arrest. Within the last 2 years, there was a paper that just came out that if you happen to be a woman and you arrest by bystanders, you're less likely to get bystander CPR. And we know from the American Heart Association that rapid treatment with bystander CPR saves lives. If you do happen to make it to the hospital, but your heart's not working, you're less likely to get mechanical support if you're a woman. We have great heart failure guidelines. They just came out this year in 2022. They're phenomenal. It's a great read. I highly suggest reading them if you have a little bit of free time on your hands. But what we know that women are largely underrepresented and understudied in these trials. We know that heart failure in women is somewhat different than it is in men. There are absolutely gender-specific heart failure entities such as postpartum cardiomyopathy, so weak heart muscle associated with pregnancy. And women are more likely to have heart failure with preserved ejection fraction. Now, I'm super excited because what we're learning more and more is there are therapies coming down the pipeline that may be targeted to those women with diastolic heart failure that we've not had in the past 40 years. So I'm excited about this quite a bit. So I finished med school quite a long time ago now. When I left med school, there was this learning or this teaching that something happened at menopause. And before menopause, women didn't get heart disease. After menopause, and what happens in menopause? Well, we lose the protective nature of estrogen. That's what happens in menopause, right? But somehow, magic things happen at menopause, and all of a sudden, you're at risk for heart disease. I'd like to turn that paradigm on its head. I think that my young daughters, who are now 11, about to enter into that phase of their life that, is a little bit like adolescence and puberty, they're at risk for heart disease. If you smoke as a young person or use e-cigarettes, you're at risk for heart disease. Absolutely. I've shown what happens to us in pregnancy is a stress test for what's going to happen future in life when it comes to cardiovascular disease. What we use for contraception, especially if we smoke with contraception, can lead to an increased risk of heart attacks and strokes. Our weight does impact it, more so if it's pregnancy weight that hasn't gone away or you haven't breastfed. That can actually impact. The overlap between cancer, especially breast cancer and heart disease, is huge, and we're just at the tip of the iceberg to understand all the risk that these women are under. Autoimmune disorders, also a burgeoning field, cardiorheumatology, where we're learning how the overlap between those rheumatologic risk factors, that chronic inflammation, plays a role in cardiovascular disease. And then again, I can't stress this enough, depression, our emotional well-being and our emotional health impacts not only our risk for developing heart disease, but if we do have heart disease, maintaining that sunny, positive attitude and having a good outlook actually has been shown with better outcomes after having a heart attack, needing bypass surgery, or having stent. And then, of course, hypertension. The thing that we should do much, much better in this country is getting everybody to hypertension. So back to this article from May of 2021. The Lancet group of writers wanted to work towards decreasing the burden of cardiovascular disease in women around the world by 2030. And how do we go about doing that? Well, number one, advocating and raising awareness for cardiovascular disease amongst not only physicians, but women across the country. I think we actually need to improve guidance on prevention. 80% of what I do is preventable, whether it be in cardio-obstetrics clinic or my general cardiology clinic. We need to do a better job of referring women to cardiologists, test appropriately, treat and prevent as we need to. And we should take our wonderful guidelines. Again, I will urge you to read the heart failure guidelines if you have some free time. And we need to apply them across genders equally. If we just did the bare minimum of those three things, I think we'd be well on our way to reducing the burden of cardiovascular disease in our neck of the woods and hopefully across the world. And with that, I'll stop. Thank you.
Wow, that was an excellent presentation, Dr. Saxena. And hello, everyone. My name is John Rickert. I'm the virtual event lead here at the Minneapolis Heart Institute Foundation. And at this point, we have reached the Q&A section. I did put I put instructions in the chat pod how to ask a question. The best way is to actually use the Q&A pod. And what you do is you drag your cursor across your Zoom screen to access the toolbar. And from there, go ahead and click on the Q&A pod, and you may submit questions anonymously. Now, as those questions come in, we do have some questions that came through during registration. And the first of which is, at what age should younger women start thinking more seriously about their heart health, especially if heart disease runs in the family?
So I have a 9 and 11-year-old. I think they should be concerned about their heart health. And what do I mean by that? I think they should get out and move. I think that they should try to have good, healthy habits, not smoke, eat that rainbow of vegetables. Yes, it's hard to get 11-year-olds and 9-year-olds to eat their vegetables. Try to maintain a healthy weight. And when they hit their 20s, I'm going to have them get their cholesterol checked. We should make sure we understand their cardiovascular risk. But then, as they age further, because they do have a strong family history of heart disease, both my girls, I would ask them, probably about the time they're in their late 30s, early 40s, especially if they're high risk with their cholesterol or with their blood pressure, to think about getting a coronary artery calcium scan, which will then show us whether they've developed subclinical atherosclerosis or plaque buildup. And then if that's the case, they should be aggressive about taking care of it. During pregnancy, during that interpartum period, it's important to pay attention to not only our blood pressure, but our blood sugars, because those things impact our risk later in life, and then that can become multiplicative. So I would say there isn't an age where you can't start thinking about cardiovascular disease risk prevention.
Absolutely. Thank you very much for that response. So, this is a common question that has come up several times. How much exercise should people, and women in particular, get in order to maintain a heart healthy lifestyle? And does this change at all during pregnancy?
Yes, and here's what I'll say. Exercise in women seems to have no bottom. Where in men, the exercise dose, this is how much aerobic fitness you have in a week, so leisure time activity that's led to aerobic fitness or aerobic exercise. In men, there's a U-shaped curve where, once you get to about 40 to 75 metabolic equivalent threshold, so this is pretty aerobic. This is about running maybe about 15, 20 miles per week at a good clip over 5 miles per hour. Men, the benefit kind of flattens out. For women, that benefit continues. So there isn't a threshold that isn't okay, meaning you can exercise more. Women tend to recover better with higher endurance activity. Women tend to actually get benefit. And there isn't a point in your life where you can't start. Now, if you've exercised your entire life, you should continue to exercise your entire life. To bring up the pregnancy part, we actually have studies looking at walking in pregnancy and maintaining a mild to moderate amount of aerobic fitness. Again, I always say you want to be able to talk, not like me because I talk in paragraphs, but able to get your words out and feel comfortable during pregnancy when you exercise. But we do know that exercise, especially aerobic activity, may actually lessen the risk of developing preeclampsia. What if you start exercising later in life? Well, it turns out that if you're a woman and you start exercising in your 40s, you will actually reap benefit, maybe a little bit more so than those individuals that have exercised their entire life. So I'm not saying give up exercise, because it turns out if you're an early exerciser and you give it up, your risk actually goes up later in life. But if you're not exercising now, you happen to be over the age of 35 or 40, perfect time to start. How much should you do? Well, 5 minutes is better than 0 minutes. 10 minutes is better than 5 minutes, and so on and so forth. There isn't a point where you can't do it. And then what do I tell my patients? For those of you who know me, I love Lady Gaga. And I always say, if you can sing the whole Lady Gaga song through, you're not working your heart hard enough. You should be able to sing the chorus, but not the verses. And that actually gauges how hard you're working your heart rate, just like being able to talk.
Yeah, that's fascinating, and thank you very much. So another common question is regarding COVID. And is there any research or information regarding how COVID, and in turn, cardiac considerations from contracting COVID, affects women differently compared to men, or just affects people in general?
So COVID, the research that's come out with COVID, there was a really, really large study that was actually just published within the last 2 months. But it was a VA population. The majority of those, of course, are men, and the majority of those, of course, are white. And these were individuals who had contracted COVID prior to the inception of vaccinations. So we don't have a ton of data about COVID post-vaccination series, and so I can't speak to that. But we do know that in individuals who've developed COVID prior to vaccinations, men are actually more likely within the first year after COVID to have a heart attack. It is a pro-inflammatory state. Women, less so. It turns out that COVID doesn't necessarily increase our risk for developing heart attacks, kind of the traditional Hollywood atherosclerotic heart disease. But we are more likely to have issues with arrhythmia and microvessel dysfunction than men. The other thing that has happened with COVID is, turns out that women have seen COVID a little bit differently in the sense that it has affected our emotional well-being far more than it has men. So from the level of stress, staying at home, depression, leaving the workforce, all of these things have impacted kind of how COVID has impacted women. So stay tuned. There are studies being done right now about those individuals who have had COVID after vaccination. We just don't know what those outcomes are. But COVID is a risk factor for cardiovascular disease and arrhythmias.
Yeah, thank you for that. It makes a ton of sense. It's very interesting. So there's a couple other questions in the Q&A pod. This is another common one. And where can folks find the heart failure guidelines that you had referenced?
Oh, so on Google, American College of Cardiology, so it's the ACC Heart Failure Guidelines 2022.
Thank you very much. So there was another question about, sorry, I'm trying to look for it here, but it was is someone who has coronary artery disease and are considered getting pregnant, should they see a cardiologist prior to that process?
I would recommend that they see a cardio obstetrician, so somebody who works in a cardio obstetrics multidisciplinary format and actually have preconception risk assessment. It will actually make your pregnancy less risky going forward.
Absolutely. Thank you very much for that. And unfortunately, folks, we're not going to be able to get to all of these questions, but let's just do maybe 3 or 4 more. So the question is there a clinical trial right now for broken heart syndrome?
So we have a inpatient clinical trial right now that's ongoing for broken heart syndrome, and that's for individuals who are presenting acutely, meaning you've broken your heart, you're in the hospital, and that's the MRI study that I showed the abstract slide from. We don't have a chronic follow-up broken heart syndrome study that's ongoing right now.
Thank you very much. And I did include a link in the chat pod earlier just to link to the research that Dr. Saxena is facilitating. So go ahead and check that out. So this is another common question, and it has to do with blood pressure. And if you could give an ideal blood pressure for older women, this attendee asked specifically over 70, what would your response be?
So my response is what the American College of Cardiology and the American Heart Association recommends. And right now, as long as you don't get lightheaded, dizzy, you're not falling, there's no other risks involved, a normal blood pressure is less than 120/80. When they looked at these trials that changed the guideline recommendations in 2017, this was all comers. We don't have an age-related normal blood pressure anymore.
Thank you very much for that. So this question is about sleep and heart disease. I know you had mentioned that in your presentation, but what is the overall effect of sleep on heart disease, and is there any studies that are taking place currently?
So not my area of interest. I not studying sleep and heart disease, but absolutely. Turns out that if you are sleep deprived, you're probably in a chronically stressed, not emotionally stressed, but physically stressed state. And we do know that sleep deprivation leads to increasing risk for cardiovascular disease. What's more so, if you have sleep disordered breathing, such as sleep apnea, there's a huge association with things like atrial fibrillation. And so again, sleep is hugely important for our brain to rest, our heart to rest, and really our adrenal glands to calm down so we're not all stressed out all the time.
Absolutely. Thank you so much. So there are actually a couple questions that are quite encouraging to see, but how can I, meaning an audience member, become a better women's heart health advocate?
Well, you're going to talk about this, so I might plug it quickly.
Yeah.
Join the foundation, work towards educating your friends and family that heart disease is the #1 killer of women. Have the loved ones that you are taking care of get their cholesterol checked, get their blood pressure checked, and join in to things such as this, the Hope, Health, and Humor, which is looking at and talking about women's heart health. John is going to talk about this a little bit more. But I would say raise awareness. Raise awareness that heart disease is the #1 killer of women in the United States.
Yeah, completely agree, and definitely something that MHIF is striving to achieve. I do like to end on this question, and it's what are you most excited about regarding the future of women's cardiovascular research?
Wow, what am I not excited about? I have a very niche interest in small vessels, microvessels, and pregnancy. And so if you were to ask me, my ideal is looking at the overlap between those small vessels and pregnancy and how risk-enhancing factors are associated. But the things that are coming down the line and coming down the pike is I think we're going to see a lot more gender-specific and as well as gender uniform studies involving women in the sphere of arrhythmia, in the sphere of heart failure. What's super exciting to me is that there is a national trend as well as a regional trend to get more women and women of color involved in research. And so to go backwards to your last question, to end on this note, if you happen to be a woman and are at risk for having heart disease or have heart disease, please call and get involved in research. Not only will you make me excited and happy, but you'll be helping people in the future generations like my daughters.
Absolutely. Well, I think that's a great place to end. Dr. Saxena, thank you so much for your time and expertise. And thank you to everyone for joining today's session of On the Pulse. We do greatly appreciate your attendance. In the chat pod, I did just put a few links, including instructions to sign up for the next On the Pulse session, which will feature Dr. Jason Gupta, who's going to present on heart rhythm disorders. And there's also links leading to additional information about the Minneapolis Heart Institute Foundation and the research that Dr. Saxena is involved with through the Penny Anderson Women's Cardiovascular Center. Lastly, as you can see on the screen, please save the date of August 24th and join us for this year's Hope, Health, and Humor event set to take place at Quincy Hall in Minneapolis. This educational, inspiring, and fun evening will be focused on women's heart health and will feature a presentation by Megan Tampty, who's the co-founder and CEO of Evereve. And in addition, the event will feature a panel of female cardiologists from the Allina Health Minneapolis Heart Institute, and of course, excellent food, drinks, and shopping opportunities from local Minneapolis marketplace vendors. So those invitations will go out via email in early June, and be sure to check out our website for updates. And with that, thank you so much for joining us, and thank you to Dr. Saxena for your time and expertise, and have a great rest of your day. Thank you.